Welcome everyone to the February 23rd, 2021 COVID-19 clinical rounds. This one focused on new clinical patterns. My name is Richard Hunt. I'm an emergency physician serving as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration, and thank you to the multiple professional organizations who have collaborated on these rounds. They are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience rather than recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC has webinars complementing these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds are currently all noon US Eastern Time. Mondays are EMS, Tuesdays are critical care, and Thursdays are emergency department rounds. This Thursday's emergency department rounds will extend out beyond the emergency department. We'll have a presentation on COVID obstetric patient care. Our HHS Emerging Outpatient Therapeutics series are on Wednesday. This Wednesday will be on equity and underserved populations. I'll now turn this over to Dr. Struminger. Thank you.
Thank you, Rick. And again, welcome everyone, particularly to all the participants who have taken time out of your busy days to join us, and to all our panelists and guest presenters. Just going to run through some of the usual housekeeping as a reminder, particularly for those who are new to the rounds. We really appreciate your questions, so please share them with us in the Q&A feature at the bottom right of the Zoom toolbar. If you have any technical or logistic issues, go ahead and mention those in the chat. We'll try to help you out as best we can. We are recording today's session as we always do, and your attendance is consent to be recorded. Thank you for that. The recording, along with today's presentations, will be made available on the Clinical Rounds website, and we'll share a link in the chat so you can access those. The recording should be up within a day or two, and the full archive of the nearly last 12 months is also there. We will be offering CME and continuing professional development credits through the University of New Mexico, where Project ECHO is based. There should be a link in today's email announcement, and we'll put it in the chat about 15 minutes before the end of the session. And the survey will stay open for about 48 hours. So you've got time to take 2 or 3 minutes and give us your feedback on how we're doing and what you would like to see the focus of topics in the coming weeks and months. Just as a reminder, these learning sessions are focused on improving patient care and health systems and supporting clinicians. Please let's keep them apolitical and non-commercial. Thank you for that. Just a note about data use. The data you share with us when you register, when you respond to the polls, when you put questions in the Q&A, we take data stewardship very seriously and keep your data confidential. Most of it is de-identified up front. What isn't, we de-identify, and everything that's shared with Rick and Esper is de-identified. Rick mentioned that NETEC's webinar series NETEC is a partner in these clinical rounds, and they have their own webinar series. And tomorrow, February 24th, they're going to be doing a session on saliva testing, and recommend that you take time, if you can, to watch it live. But if not, they also have a great archive of all their webinars. Rick mentioned that we're supporting a special mini-series on monoclonal antibodies and outpatient therapeutics. As he said, tomorrow's session is focused on equity in underserved populations. We'll share a link to the registration in the chat and welcome any and all to join us. Also, the Association of American Medical Colleges is a partner in these clinical rounds. Since last March or April, they've been supporting a clinical guidance repository, which they update regularly, and it's a great resource. We'll share a link to that in the chat as well. Rick, back to you for today's crowdsourcing question.
Thanks. Given that we're talking about new clinical patterns or potential new clinical patterns, this question is pertinent. If you have seen some patients with new patterns of disease in some COVID-19 patients, have they required changes in clinical management? If so, what changes? Thanks, and we all learn from each other when you respond in the chat, so much appreciate your responses will be very much appreciated. With that, I'm going to please ask the panelists to take themselves off mute. Actually, it's a special honor to have our panelists introduce ourselves today with I guess special guest panelist, but also previous speaker, Dr. Chris Meadows. Chris, if you wouldn't mind taking yourself off mute and introducing yourself, we'd be most appreciated.
Sure, Rick. Thanks very much indeed. And good to see everybody again. And looking forward to lively presentations and some discussion. So I'm a critical care intensivist consultant in the UK. I work in London. I work in University Teaching Hospital. It's probably the biggest in the UK, actually, in terms of overall bed numbers and academic output and so on. And I'm just here really to try and give some reflections and observations on the two major surges of COVID cases that we've had in the UK over the last 12 months, and perhaps to draw out some distinctions between those two waves, if that's okay. Most of my job involves ECMO, so that's the angle that I'll be taking.
Appreciate that, Chris. And if each of the other panelists can take themselves off mute and briefly introduce themselves. James Lawler. James, welcome. Good to see you.
Hi. Thank you, Rick. It's been a little while since I've been on. I'm an infectious disease physician from University of Nebraska Medical Center in Omaha.
Thanks. Doug Kubas.
Hi, Doug Kupas. I'm an EMS physician and an emergency physician at Geisinger Health System in central Pennsylvania. I also serve as the state's EMS medical director.
Thanks, Doug. Jeff Dichter, please.
Hi, I'm Jeff Dichter, a critical care physician from the University of Minnesota.
Jeff, thanks for being on, and thanks for leading a wonderful series on mass critical care over the past few weeks. Much appreciated. And Laura Evans.
Thanks, Rick. Great to be back. Laura Evans here, pulmonary critical care and the medical director of critical care at the University of Washington Medical Center.
Thanks, Laura, for being on. Carol.
Good morning. I'm Carol Cunningham. I'm an emergency physician. I'm the state medical director for the Ohio Department of Public Safety Division at EMS.
Thanks. The format for today will be, I'll go ahead and turn this over to our speakers with Vikram first, and then Harry Seibold, and then turn it over to Dr. Meadows, and then to Laura and our other panelists for reflections. Then we have about 6 or 7 polling questions, and then final comment, and then we'll end. So with that, it's an honor to have Vikram back. Dr. Mukherjee is assistant professor at NYU School of Medicine and director of the Bellevue Medical ICU. Vikram, please.
Thank you, Rick, and hello, everyone. Thank you for your time. Over the next 10 minutes or so, I'll go over some atypical presentations of COVID-19. I'm Vikram Mukherjee. I'm the director of the Medical ICU at Bellevue Hospital Center in New York City, and I have no financial disclosures to proclaim here. These are 4 cases. The first case, and I'll keep it brief, and hopefully we'll have time for discussion, is a 33-year-old gentleman diagnosed with SARS-CoV-2 infection December 2020, mild disease, no reason for hospitalization, never hypoxic, and then tested negative in late December. And then early January, middle January, he presented with progressive shortness of breath and tested positive again for what we think is a new infection of SARS-CoV-2. He was admitted to the ICU after failure of high-flow nasal cannula, intubated, transferred to our hospital, which is an ECMO referral center for the system for ECMO evaluation. He did not need ECMO. He was able to improve from a respiratory perspective with just neuromuscular blockade, prone positioning, and inhaled NO. Surprisingly, a few days into his hospital stay, still intubated, he had an acutely blown pupil. On scanning of his head, we found completely out of anyone's expectations, an acute hemorrhage. And this was on further MRI reported as an entity called acute hemorrhagic necrotizing encephalopathy, which honestly, I had personally not heard about, but it presents with diffuse cerebral edema, had left frontal hemorrhage, and had both hemorrhagic and non-hemorrhagic necrotizing spots in his cortex. A few days later, he had sudden onset hypotension with a rapid escalation of pressors. Point of care ultrasound revealed a large pericardial tamponade, and this also was unexpected. He didn't have any bleeding diathesis. His anticoagulation was prophylactic at best, and he didn't have any classic reasons to suddenly bleed into his pericardial sac. A liter of hemorrhagic pericardial fluid was drained. The patient failed to improve with this intervention and coded intra procedure with return of systemic circulation after around 20 minutes of CPR. At this point, given his overall poor prognosis from a respiratory, neurologic, and now a post-arrest perspective, family discussions were made, and the patient unfortunately passed away very shortly. We'll come to more on the discussion, but what took us as a setback here is this presented with an initial, was a reinfection, which we were not expecting so early on after a primary infection. While his ARDS was well within our scope for COVID ARDS, the neurological and cardiac manifestations took us a little bit off guard. I'll keep it at that and then move on to case number 2. This is a 39-year-old ED nurse, 34 weeks pregnant, works at our hospital, presented with severe acute respiratory distress syndrome, required emergency C-section, and was extubated 5 days post-op. Again, this is a classic picture. We wouldn't think much about it. This is a pregnant lady. We know that pregnant women are at higher risk, up to 70% for COVID ARDS. But then we heard from Dr. Meadows a note about how in the NHS in the UK, 600 pregnant postpartum women admitted to hospitals with COVID-19 in their second wave, almost entirely from the B117 strain. And we'll hear more about this, I hope, from Chris later down the line. But we have sent this patient's samples for whole genome sequencing and are eagerly expecting the results of this test. The third and fourth cases are something that we saw a little bit in the first wave, but are seeing more with a huge amount of bias in this wave as well, are MISC/MISA, multi-system inflammatory syndromes in children and or adults. The first case here, this happened all in the last 10 days, 20-year-old male, COVID positive in early Jan 2021, mild upper respiratory infections. 2 weeks later, so well within his COVID diagnosis, he presented with fever, tachycardia, shock state with multi-organ failure, which included kidneys, liver failure, respiratory failure, and it turned out to be cardiogenic shock driving the etiology of his hemodynamic compromise. He recovered with high-dose steroids and IVIG, and almost all his organ function has recovered by now. His inflammatory markers are quite impressive. They're on this table on the left with peak CRPs in the 500s, D-dimers, ferritins, LDHs, and procalcitonins, all much higher than the expected range of normal. Similarly, a very young gentleman, 22-year-old male, presenting as a trauma victim, and on admission, routine screening for COVID turned out to be positive. Who knows when he had onset of symptoms or whether he was completely asymptomatic from a COVID respiratory perspective, but soon after his admission, very similar course, cardiogenic shock, acute kidney injury requiring renal replacement therapy, liver failure, respiratory failure, and again, improved with steroids and IVIG. He also ended up having a PE with a clot in transit in his right ventricle, which was extracted. On the table again, a very similar story as of our third case. Very high inflammatory markers, CRPs, D-dimers, ferritins, LDHs, and procalcitonins through the roof. The reasons that we bring this up is because, of course, all of us on this call are a little bit concerned about these new variants and how much of this is spreading through our communities. This is a slide as from yesterday, which shows that there are 1,600 cases or so of B117, and of course, this is a gross underreporting of data based on our capacity to do whole genome sequencing. And the B1351 and P1 are present here, and unfortunately, are pretty sure to be spreading through our communities as we wait for further sequencing to be able to identify this. And again, this is probably more up Dr. Meadows' alley, but this is how the second wave in the UK evolved after the B117 was first detected, and probably had a lot, these waves here probably had a lot to do with the variant strains, but I'll leave that for Chris to describe. I just want to bring up, and James, thanks for bringing this to our attention during a recent NETEC call. The Manaus experience in Brazil is educational and informative at best. As you can see here, the first spike here in around April or May of 2020 left the city with around a 76% seroprevalence of antibodies. And you would imagine at that level, there would be herd immunity, if you may, a 76% seroprevalence. But as you can see here, as the community opened up, as restrictions and social distancing eased up, they had a horrible, horrible second wave, which was attributed, among many causes, to the P1 lineage or the Brazil strain. This is a very interesting read. This citation, they go over multiple possibilities of why this happened, but one of the possible reasons is that the P1 strain did not follow herd immunity rules, and the antibodies that people there had from the first wave were not protective against the P1 lineage. So just to keep it brief, some thoughts. Again, I would like to emphasize that these are anecdotal cases at best. These are 4 cases among hundreds of patients that are coming into our ICUs. And of course, there's a huge selection bias. We are the cardiology referral center for our system. We are the ECMO referral center for our system. So we're getting a lot of sick patients, and this is by no means the only trend that we are watching here. But of course, the balancing factor are these early warning signs. Is this what happened in Brazil and the UK as there's waves developed and left them somewhat devastated? At the very least, I would say that this emphasizes that we cannot drop our guard, even with vaccinations, even with prior infections. It doesn't mean that we stop our social distancing, we stop wearing masks, stop wearing our PPE. There is an obvious need for expanded capacity for whole genome sequencing, not just in the ICUs, but also in the community level, to see what's spreading where and how quickly. And the last thing from a clinical perspective is we should be aware of atypical presentations. Just because someone's presenting with cardiogenic shock in the correct scenario, a COVID diagnosis should be somewhere in the differential, even though it might not be the top diagnosis. So I don't want to cry wolf based on these 4 or 5 cases we've seen, but I'd rather have this as a hypothesis generation subject for discussion among everyone here. Like, is this an early warning sign, or is this just something that we are overreacting on? Over and out, and thank you for your time.
Thanks very much. I'm going to turn this over to our panelists. I'll take 2 questions, and I want to get to Harry and then to Chris. So 2 questions from any questions from our panelists? Laura, yeah.
I'm always good for a question or 2. Thanks, Vikram, for that. I think it's super interesting, and I think the astute observations of clinicians at the bedside are incredibly valuable for this. I'm curious about a little bit larger question rather than beyond the cases that you presented, in terms of how you've incorporated measurements of inflammatory markers into your care for these patients, because you reported inflammatory marker parameters on these 4 cases. Were these sort of triggered and specific to the clinical presentations there, or are you still measuring routinely, and are you using these markers as to influence treatment decisions in any way? Over.
That's a great question, Laura. We are still measuring our inflammatory markers routinely. And again, I agree that this is not an evidence-based approach by any means. And sometimes, especially in the patients who are in extremis, we are basing some immunosuppressive therapies based on how high or low the markers are. We are still, and again, I repeat, this is not evidence-based, but we are following D-dimers to strategize our anticoagulation pathways, but with a very careful risk-benefit ratio decision point. But keeping it short, we are following inflammatory markers, and some steroids and anticoagulation therapies are being based on where the markers are headed towards.
Thanks, Vikram, and Laura. Kind of feels like you're back on rails together, doesn't it? Let's see, next. Another question? If not, I've got one. Vikram, so and you and I have talked about this some and back and forth in email and so forth, and others, and I have as well. Okay, so arguably your center may, I mean, I don't know how many patients you've seen, but you've seen far more than most places, most hospitals. So if you were, and it can't be more than a guess, but your best guess, do you think that these cases that you presented, do you think it's just like you've just seen more and more patients and finally these ones popped, or do you think they are variant cases? And I know there's no, but your guess, your gut tells you what?
Just gut, and I hope that I'm completely wrong. I think personally, without any data to support me, that these are variant cases, especially the first two. The first one, especially because it was a reinfection so early on after his initial infection, and he was negative between the two tests, and his presentation was completely unexpected. We expect an ARDS pattern, of course, but a brain bleed, a pericardial bleed, I still don't understand the pathophysiology of how that happened. And the second one, we know that B117 is circulating in the community. Chris's note about how almost entirely his waves, pregnant women, were B117 makes me at least question whether our pregnant lady, who thankfully is better now, had a variant strain. We eagerly await the genetic sequencing results, which are cooking right now.
Yeah, thanks, Vikram. Appreciate that. With that, I'll turn this over to our next speaker, Harry Seibold. Dr. Seibold is an emergency physician and the EMS medical director in Helena, Montana, and we get to have him present again. He's always been an extraordinary contributor, both presenting and also as a panelist for many rounds. So it'd be great to hear from you, Harry, on your experience with this.
Sorry about my little technical glitch there and going backwards. I hope everybody can read backwards very rapidly. So Vikram is always a difficult act to follow. And I've got a few cases to speak about, but I'm going to talk a little bit about more general observational trends that we've noticed where I am. Rick did mention that I'm an EM and EMS physician in Helena, Montana. I've spent most of the last year focused really on COVID, first in Missouri, setting up alternative care sites, and then for the U.S. Forest Service out in COVID surveillance and on fires. But most recently, since November, I've been in West Texas on a COVID response and assisting in the ICUs here. So a lot of my observations based on what I'm seeing in our region down here. So this is me. Unfortunately, I have no financial disclosures to make. And we're going to talk some about evolving patterns. None of these people have signed on to this this presentation. Those are just organizations that I work very closely with year to year. And the good news is some things about trends. It appears that numbers of new cases are going down. Our numbers of deaths in the US seem to be going down, and perhaps even severity of disease may be going down. A little early to tell on those things, but we're starting to feel a little bit of good news. But the bad news is that we're still seeing new cases and new hospitalizations every single day, and those hospitalized patients are still getting significantly ill and requiring ICU admission. And the question is, are we seeing new patterns? This came up, I think was born based on some green room conversations we had before a previous echo of some discussions, and then people on opposite sides of the country, we noticed, hey, I'm seeing that, you're seeing that, but we haven't seen anything in the literature about that. John Jew did a great presentation yesterday in our EMS rounds talking about variants and strains and those things. So here we're really talking about new patterns. As Vikram said, perhaps some of these are related to variants or strains, but we don't have that data. We're really looking at the observations of the new patterns. And I'm going to look at it kind of in through two different windows. One, the evolution of patients during their hospitalization and patterns of disease that we see on presentation to the hospital. And again, this is observational information, so it's not truly scientific information or research. Vikram had some great statistics there, but let's remember that the scientific method is based on observation to develop a hypothesis and then to go out and test that hypothesis. So our observations are very valuable in moving forward with the scientific method of studying this disease, and that's going to go on for years to come now. We all know that. So my goal with us today really is to stimulate some thought and discussion about the current landscape of COVID, not necessarily to provide you with hard scientific data. And I'm going to focus on kind of 3 organ systems and what I'm seeing, and we'll move quickly through that. And again, I hope we'll have some time for discussion at the end of that. This all started as we compared some notes and said, you know, I'm seeing an abnormal number of people with pneumothoraces and pneumomediastinum that's way out of proportion to what I'm doing with their ventilatory dynamics. These are sometimes people that are not intubated, or if they are intubated, they're on minimal settings, but we're seeing those things way out of proportion. And I'll just show you one quick case. So this is one patient of mine who was a young person. I'm not going to give a lot of identifying data for obvious reasons. Only previous health problem was hypertension prior to coming to the hospital. Had some upper respiratory symptoms, was found to be hypoxic and was admitted ultimately on high flow oxygen and then transitioned to BiPAP. This is his chest x-ray 2.5 days later. It took us an entire day of speaking to him to get him to allow us to help him and to intubate this patient. He said, no, I don't want that. He was 20-something years old, and we felt it really is in his best interest to intubate him because clearly we could see which way he was going. This is the same patient's chest x-ray 2 months later. This was 2 months of intubation. And I will tell you, there were entire weeks where we had to speak every day with the mother saying, I think your son's going to die today. Vikram would be aghast if I told him the PEEP levels we had and the peak pressures to maintain oxygen saturations in the 40s and 50s, which I didn't think were compatible with life. And I'm a little choked up. This person's going to go to rehab today. And he's speaking, he's a singer, he's moving, and he's going to leave the hospital. It's pretty amazing. This is one of my new admissions from this week. Unlike this other person who was on incredibly high levels of PEEP, peak pressures in the 50s for weeks, never had a pneumothorax, never had a pneumomediastinum. This person came in, and because of his work of breathing, almost more than his SATs, his work of breathing was how he got intubated. He was just barely above physiologic PEEP. And within 24 hours, you can see that he has a left apical pneumothorax. He's developed pneumomediastinum and has significant amounts of subcu emphysema. And it's just striking to me that there is something in there that we've yet to identify that's giving us this kind of presentation. This person's a non-smoker, relatively young, no emphysema, no history, yet with minimal settings, this person developed pulmonary complications. As of yet, I have not had to put a chest tube in on this patient, but I'm kind of poised at the bedside every day when we're around and in between, because I understand where this can go. I've put in more chest tubes in the last 3 months than I've put in the last 10 years. Next, talk a little bit about some of the GI presentations that I've seen. And this was basically born out of a conversation just this past week. So it's kind of timely, Rick, that you invited me, and I appreciate that. We had a discussion with physicians of multiple different specialties, and one of the surgeons said, "Why are you guys in the ER still testing people for COVID when they come in and they don't have any respiratory symptoms?" Well, all of my colleagues throughout this region have noticed that we're seeing significant numbers of people that come in without respiratory symptoms that have simply GI presentations, some mimics of early appendicitis, some say I have food poisoning, and ultimately they test positive for COVID. Some have only GI complaints, but once you test them and when you get their full set of vitals, they are happy hypoxics as well. So this seems to be somewhat different than what we were seeing in our early waves, where yes, we were seeing people with GI complaints, but those GI complaints were almost always accompanied by respiratory complaints, anosmia, weakness, or other symptoms that would key you to looking specifically toward COVID. And the last set of things that I'd like to bring up for discussion is basically the endocrine complications show, so to speak. We all know that our patients, once they're admitted to the hospital, especially once you're in the ICU, many of our COVID patients have glucose instability, whether or not you came in with a pre-existing diagnosis of diabetes. But I have seen what appears to be a trend of more people that come in with vague complaints, and it's only upon testing that this person who has no pre-existing diagnosis of diabetes, has a blood sugar of 650, has an anion gap and an acidemia. And it's surprising to me. I suspect that some of these people had incipient diabetes and their A1Cs were elevated, but the question is, if that person had simply had influenza B, and we are seeing co-infections with influenza B down here as well, would we have seen this same kind of glucose instability, or is that some other effect of the SARS-CoV-2 virus? I've had a couple of friends who have had very mild cases, but began having unusual symptoms of neck pain and ultimately were diagnosed with probably a benign thyroiditis. But when they went and sought follow-up, the endocrinologists were not at all surprised. So apparently they are seeing this later in the post-infectious stage, where they're seeing people that are presenting with this thyroiditis. And adrenal insufficiency, I just wanted to make that noted, that remember, our common things happen commonly. Our patients that come in and we put them on protocols with remdesivir and relatively high doses of dexamethasone, later in their hospital course, when you have unexplained hypotension, don't forget that some of these people are having secondary adrenal insufficiency, and we need to consider those things. It's not always the virus itself that's causing the problem. It's not always because of that. Just a quick observation, I am starting to see people that have come in the hospital, been discharged, and now are being readmitted, not necessarily, I believe, because of a reinfection, though on their testing, especially their PCR testing, they are still testing positive, but a significant number of those on antigen testing are testing negative. I believe it's not that that's a false negative. I think it's, once again, we're seeing people that are shedding non-infectious particles, and the PCR is sensitive enough to pick that up, but our other testing says you're negative. But they are seeing the kind of reaping the results of all of the damage of the SARS-CoV-2 virus, especially the pulmonary complications, the diabetes, and the renal injury that was noted over in the chat. So we're starting to see those. And one final observation, I'll give you a short, not even a case presentation, but an observation. We've had 2 family groups that have come in with entire family with quite significant infection with COVID. As a matter of fact, one family group, I believe, before this is all over, they will all have passed. And I believe, in looking at these 2 family groups, that this is not simply where we're seeing, say, a racial significant, like in our Navajo tribes, or that we're seeing the effects of disparities. I believe this is familial traits that that we're seeing, because it's so distinct that every single member of this family, from the youngest to the oldest, got very sick with this. So I think that there's probably some familial genetics in certain groups. And I believe Vikram's observation that we're going to really need to do more, not only of our genomic surveillance of the virus, but also when we see these types of familial groups, perhaps dig deeper into that and see what is the familial trait that's causing these folks to become significantly ill with SARS-CoV-2, and perhaps that may be one of our routes to finding treatments. I'm froze for a moment here. There we go. I just want to thank everybody for all the hard work that you're doing out there, and for staying on board with all of our ECHO presentations. And much like what Vikram said and stole my thunder, maintain your vigilance. This is a sneaky virus, and I believe will continue to challenge us in the coming months. So feel free to contact me offline or online at any time. There's many ways to get a hold of me. And if we have any questions along the way, I'd be glad to entertain those.
Harry, thanks very much for the presentation, and an appreciation for your actually choking up. And I mean that sincerely, in that after seeing that we passed 500,000 deaths here in the United States, being able to not be numb to this and choking up around successes and those patients who have died is probably really healthy, and I appreciate you doing that. So over to Vikram. Any questions? You presented. I want to make sure you got a opportunity to ask Harry or have any dialogue with Harry, and then I'm going to turn it over to Chris Meadows.
No questions, Rick. Thank you, Harry. Great presentation, and so glad that your patient did well. He was obviously very close to badness. Good job on that.
Yeah, thanks. With that, I'm going to turn it over to our colleague from the UK, and deep appreciation for his collaborating with us. We all know the critical importance of collaborating with our international colleagues in medicine, and particularly around infectious diseases and this pandemic. So Chris, turn it over to you for your observations. Thanks.
Many thanks, Rick, and of course you're very welcome. I'm just glad I could find the time today to quickly join you. I don't have slides, I'm afraid, but I just wanted to. I'd made some notes, and I just thought it'd be nice to go through those reflections. First of all, I just want to perhaps remind everyone, or just let you know for the first time, the picture in the UK over the last 12 months. So our first wave was really between March and May 2020, and things calmed down an awful lot. In fact, we sort of had a mini wave in the north of England during the late spring and early summer. But that settled down during the hot months, and then our second wave really got going in about October, and was almost certainly down to, I think, the sort of release of lockdown restrictions during the summertime, and that lasted through until really just about now. We're just seeing the cases coming down, the new cases coming down significantly now at the end of February. So a much longer second wave than the first wave, interestingly. And thanks, Vikram, for showing that chart about the variants. So the second wave here in the UK, at peak, almost 100% of newly admitted hospital cases were of the B117 or Kent variant, as we call it. And we know that because actually in the UK, we've got pretty good genomics, and we have routine sampling of a large minority of positive PCR tests. We do also have a number of cases. I think we're up to just around 150 total now in this second wave of the South African variants, which of course brings with it a certain degree of concern over the vaccination issues that it may represent. The second wave for us really tested our critical care capacity in the UK. At the peak of that wave, we were at, nationally, the average figure would be around 150% of critical care occupancy. So what that means is that each hospital, each institution was asked to make surge capacity outside of the usual critical care footprint and to fill those spaces with critical care patients, whether they be ventilated or on level 2 type support, mask ventilation, and so on. And so across the country, we were at 150%, but there were clear regional variations. So for example, in London, we hit around 200% occupancy for critical care. The institution where I work, which is Guy's and St Thomas's NHS Foundation Trust, which, as I said before, I think just looking at the national figures I did a few minutes ago, I think we had admitted more, and at peak had more ventilated and critical care patients than any other institution in the UK. And we were around about 250% occupancy. And we only managed to do that by converting theatre areas, theatre recovery post-anaesthetic areas, and ward areas into ICUs. We also provided an awful lot of mutual aid. And I think we touched on this the last time that I joined you, this idea that larger institutions provide benefit to smaller places by offloading patients rapidly on a daily basis. And we did that for the whole of the Southeast sector in the UK. So I think that almost certainly explains the huge increase in occupancy that we witnessed. And just to put some numbers on that, so since March last year, so around about the last 12 months, we have admitted 900 patients to critical care, and 550 of those were within what we call this second wave. So it was a bigger, harder hit for us in this second surge. What was interesting about it is that actually many staff members who had gone through the whole first 6 months of this pandemic, starting from around February, March in the UK, and had avoided contracting COVID, either at work or outside work, suddenly fell ill with this Kent variant, with this B117 variant in around about October and November last year. And I think that almost certainly relates to the denominator within the community that we were seeing and probably underestimating. And also it fits with the evidence that it is a much more infectious variant, and the transmission was probably greater through people and through staff members. We did also see there's a difference in, I alluded to it earlier on, but there was clearly a difference in adherence to lockdown restrictions by the British public in this second surge compared to the first wave. I mean, I was driving to work, which is a 20-minute journey, back in April last year, and London was empty. It was desolate. There wasn't a soul on the street, and I could do a 20-minute journey in about 10 minutes. During this second wave, adherence to those restrictions has been much less, and I suspect that has fed the number of cases and also the number of critical care admissions that we've seen. So features of this second wave that I think, so in some ways similar. So for example, we have seen the same BAME predominance, so Black, Asian and minority ethnic communities particularly affected. Also those of low socioeconomic status have predominated as well, and that has been persistent through both waves. But there have been some differences. The first thing to say is that the average age of critical care admission is around 10 years less in this second wave compared to the first. So when I talk about second and first wave, I'm really talking about the difference, I think, between these two predominant variants circulating in the UK. So a younger age is one thing. Vikram touched on the obstetric patients, and that is true. We have seen over 600 now pregnant or immediately postpartum women, so of childbearing age, 20s and 30s, admitted to hospital with COVID. The peak point in the pregnancy that seems to prompt admission is around the end of the second trimester. So it's those women who are around about 24 to 26, maybe 28 weeks gestation. And many of them have become seriously unwell. So we have around 20 pregnant women who have been on ECMO across the UK. So out of that total 600, that's quite a large percentage. In our institution, we have had 7 pregnant women on ECMO, all delivered early and appropriately. It's not been a mild illness in those patients. They're not, when I say mild, what I mean is, you know, sometimes you put someone on ECMO and actually they're going to have a fairly short run, everything settles down and you can decannulate them, you know, perhaps within a week or so. With these younger patients, and particularly the postpartum ones, they've had long runs on ECMO. They've been difficult to manage. And in fact, that is reflected across the board for this Kent variant. There's been a longer duration on ventilation. The average is up at around 20, 21 days, and even longer if they're on ECMO. But I think it was really interesting to hear Dr. Sibbald's case presentation just now, because I think one of the things we learned from the first wave here was that actually these patients just take a long time to get better, and the young ones will invariably come through. So our attitude here for this second wave has been dig your trench and settle in, you know, just dig in and keep on going. And we found that many patients that I think perhaps we originally would have thought would not survive have come through, have fallen through, you know. Now there's the question, of course, of rehabilitation and long COVID and so on, and I think that is going to be a significant burden on our rehabilitative services to come. Just a few other things to mention. You know, we've seen quite early established fibrosis on CT imaging, more so in this second wave compared to the first. The use of steroids in the UK, it's been an interesting story, and you know, there's almost been a sort of a battle between the trialists and the pure clinicians, if that's not heresy to say so. But you know, I have colleagues who are very much academically focused, who really push hard for us only to use 6 milligrams of dexamethasone as per the recovery trial. And I think many of us who have been at the bedside far more commonly have adopted a different approach. And we talked about this before, I know, and we adopted here at this institution a different approach back in April last year, but many centers now have followed us. And it's not uncommon now for patients admitted to critical care to simply go on to a 20 milligram dexamethasone regimen. So equivalent to the DEXA ARDS study, admitting that clearly that was pre-COVID ARDS rather than COVID, and the evidence base in COVID is still lacking. And I don't think there are any trials at the moment that are going to answer that question. But a larger dose of steroids we have felt is the right thing to do, and that is based on the imaging findings. It's based on the inflammatory markers, and it's based also on the clinical picture and the ventilator mechanics. And so we have a sliding scale of dosing regimen of steroids. It doesn't have to be dexamethasone. In fact, we switched to dex from methylprednisolone in my institution because there was a national shortage of methylpred. So, but we were using equivalent doses anyway. The inflammatory markers that I'm talking about, which we use to track the inflammatory process, are ferritin, CRP, procalcitonin, and also D-dimers. What's interesting is we've noticed in a very small minority of patients, the procalcitonin has been high and above the reference range, with no evidence of any bacterial superinfection. And that's really fascinating. I do not know why that might be, but generally the presentation is with a low procalcitonin, easily less than 1, and a CRP in the hundreds and a ferritin in the thousands. And those patients will receive a higher dose of dexamethasone with us. One comment to make about CRP actually, and I'm sure you've all noticed this, but every patient here now is on the basis of Remap cap is receiving tocilizumab at the point where they require respiratory support, even if that is just face mask oxygen. And of course that renders the CRP completely useless for interpretation. And when you're looking for signs of any superadded infection, CRP is in single figures for 2 weeks. And that's something that from the clinic, from the clinician at the bedside point of view, I think has been a challenge actually. The other thing I'd just like to mention is we talked just a second ago about pneumothorax and pneumomediastinum, and it's our experience that we've seen a much higher frequency of air leaks with patients in this second wave compared to the first, and there have been significant air leaks as well, and we don't know why that is. It's difficult to explain. It's possible that it is related to the duration of mask ventilation that patients have had prior to intubation. And this idea that a patient who has a high minute ventilation, spontaneous minute ventilation, high respiratory rate is probably injurious. And certainly we've admitted patients here with widespread surgical emphysema and pneumomediastinum who have not been intubated at all. And the chest X-ray will show florid air throughout the soft tissues. And so we suspect that there's a relationship between non-protective, spontaneous, high volume respiration and air leaks. Some of the large air leaks we've managed to overcome by placing endobronchial valves. And actually to have that as an option has been a bit of a lifesaver on occasion. The other couple of things that I should say actually that, and it's an interesting question, maybe we can discuss it, but the use of Cpap or non-invasive ventilation for ARDS management in this setting is interesting because it represents a significant departure from our pre-COVID management of ARDS. And I just wonder what the practice is like in across the States. You know, in Italy, we know that they used Cpap helmets a lot in northern Italy because they ran out of mechanical ventilators. And it's interesting that practice was translated to the UK and taken up by a number of enthusiasts, and that has become standard practice now for management of COVID ARDS. But there is no evidence to do that, interestingly. Anyway, the last thing I wanted to say really is just about the vaccination program we have here, and the fact that we hope we're now at the end of this second wave and that we will mitigate any further waves by rolling out this vaccination program as fast as we can. And we're doing very well, but of course, most people who've had a vaccine have only had a first dose. And so really we're running the biggest experiment in the world on vaccination programs at the moment, and we don't know what the outcome is going to be. We've had some encouraging news this week, actually, about the real world protection that a single dose of vaccine gives, but I guess we'll only know in the next 6 months or so whether that was the right thing to do or not. Okay, I think I'll stop there if that's okay.
Chris, extraordinarily helpful, really helpful. One question from any of our panelists before I go to the polls. And James, I see you got a question.
I do, thanks. Chris, great talk. It sounds as if you all are using tocilizumab now as a relative standard of care for folks who are requiring oxygen therapy. Any other immune modulating drugs that you all are using frequently in your critically ill patients?
Not in widespread use, no. Where sarulumab is available, then that is exchanged for tocilizumab depending on availability. But we don't have access to baricitinib in the UK at the moment, and others as well. There is some immune modulation with anakinra, IL-1 antagonist, in those patients who exhibit the signs of HLH, but otherwise there is very poor access to any other immunomodulators. It's an interesting question because, you know, based on the REMAP-CAP study, our chief medical officer has recommended tocilizumab in COVID patients within the first 24 hours of respiratory support. But recovery has also reported with far greater patients. And although they've on social media, there's been a big clamor and backslapping event about the success of that trial. Actually, I think many of us are just slightly more circumspect about the results, particularly in the mechanically ventilated patients. And I think we're perhaps just not sure that the marginal gains are as great as they claim to be, particularly in patients who are receiving a higher dose of steroids. And the question really is whether giving a low dose of steroids, so for example, 6 of dexamethasone plus tocilizumab, may be equivalent to giving a higher dose, 20 milligrams of dexamethasone. And we don't know the answer to that. Thanks for the question.
Thanks, James, for the question. Doug, I saw your hand, but if you can hang on. I know people like have the 1 o'clock meetings or you got to go to lunch or whatever, but if you can hang on for the polls, the polls will probably, there's like 6 questions. And then after that, we'll have a final round of discussion. So if you can hang on at least for a little while this time, that'd be most appreciated. Okay, if you can put the polls up, please. Okay, this one's really straightforward, okay? Since January 1st this year, I have seen new patterns of disease in some COVID patients. Okay, so the limitations of this paper is, okay, so we titled the rounds new patterns. So you figure those that might have shown up got that, but it's really helpful to know what's out there right now. All right, another 5 seconds or so, we'll stop. All right, let's stop there. 37% voted, 41% indicated yes, 59% indicated no. All right, so the next series of questions, go to the next question. The next questions are, there's an and clause for these next questions. So if you answered yes, you have seen new patterns of disease in some COVID patients. And most of those patients are, and I'm trying to get to the age group and the pregnancy piece, okay? So these next questions are for those of you who answered yes, you're seeing new clinical patterns. All right, let's stop there. 56% indicated 19 to 44 years old. All right, next. Okay, so you've seen new patterns of disease since January 1st and compared to other COVID patients, their clinical courses, and it's about severity. On the question of whether or not people have seen new patterns in some patients since January 1st, this is the 4th time we've asked that question since the first week of February. And each of those polling questions have received 25%, and I think the highest was 37% indicated they had seen new clinical patterns. All right, let's stop there. It's quite a distribution here. All right, thank you. Next. All right, so you've seen new patterns of disease since the beginning of the year, and those new disease patterns impact which of the following the most? Vikram, thanks very much for being on. I know you got a 1 p.m. Really appreciate your participation. Another 5 seconds on this one. All right, let's stop there. Carol, as soon as I saw that vascular clotting, I recall your comment about how you saw like a bunch of, I think, arterial thrombosis, right? Something like that. Yeah, recently. All right, thank you. Next. Since January 1st, you've seen new patterns, and those new patterns of disease have required changes in how you manage those patients or no changes in how you manage the patients. All right, let's stop there. Oh, that was a 50-50 split. That's the first time in all rounds I think I've seen a 50-50 split. All right, next. Okay, you've seen new patterns of disease, and the setting you're seeing those patients is where? Hey, Chris, while people are answering this, for UK, is it mostly in the units where people are saying this is different, or is it kind of across the board in other settings too?
Yeah, it's mostly within critical care.
Yeah. Which, to me, as Harry was talking about in the green room, it means, they're advanced in their disease. It's not like, at the very beginning, and so those complications are coming later on. Yeah. All right, 5 more seconds. All right, let's stop there. Interesting. Yeah, the ICU, but then the ED and some in the EMS as well. Interesting. Okay. Let's keep it up there for a second because people haven't, I saw it as it was happening, but you didn't see it. All right, the next one, and if it's what I think it is, you just kind of hang on before you like jump on this next one. Yeah, okay. So this one. All right, so this is like if you've seen new clinical patterns, it's like where are you seeing them by state. So look for your state on this, okay? When I put this together, it's like, oh gosh, it's like test, find your state. Give it another 10 seconds. This one's important. It's trying to get to like, are these in pockets or is this widespread? Obviously, that's what I'm trying to get to. All right, let's stop there. And there's some places that have seen none. And then it looks like region 9, Arizona, California, like 21%, region 6, Arkansas, Louisiana, New Mexico, Oklahoma, and Texas are kind of high rollers there, and then much lower in the other areas. All right, and then next one, I think the next one's the last one. Okay, so this is like the question, and Chris has already given us big clues on what happened there, not clues, but his experience there. But so you're seeing new patterns and you're taking care of patients in an area with large numbers of variant cases that are known variants. And, you know, this question obviously is difficult because of our, we don't have a lot of genomic testing going on right now, so it makes it really tough. All right, let's stop there. See those results. Yes, 10%, no, 41%, 48% don't know. All right, thank you. And Jeff Rubin, I see your comment there. Do geographic results simply indicate participant distribution? Sure, there's a lot of bias in all this for sure. Understand that, and it's a good point. All right, so Carol, before I turn it over to Harry and Chris for last words, yes, insights, questions, comments, speculations.
Great presentations by everyone. I think we need to, as I mentioned before, I have patients with arterial occlusions with no respiratory symptoms. So we also need, you know, I think differently now. If I get somebody with ischemic bowel, I'm going to probably test them for COVID because we don't know. And I also think, you know, data collection is so important. So again, we need to broaden our horizons. I know in an ICU, you're seeing respiratory patients, but because of that clotting thing, let's think about the folks in the surgical ICUs too, who may present differently. And lastly, with the new variants, Chris, I was so glad you could join us. We can learn so much from global input from others that are treating patients, particularly with the new variants, that it can really be beneficial to everyone. Thank you.
Yeah, thank you. Bruce, anything from you before I turn it over to Harry and Chris?
Just thanks to everyone. Thanks for everyone for hanging in there a few extra minutes and joining us. And Chris, thanks for joining after work. And it really is helpful to have this dialogue and be able to share our experience with you and hear from you what's going on across the pond. So thank you.
Yeah, thanks. Harry?
Sorry, I had to unmute. I just wanted to thank Chris for being here because getting that kind of global perspective, we tend to look internally in the US a lot of times, and it's really great to see what you're doing and compare notes on those things. And I think those are the ways that we're really going to come to solutions at the end of this whole journey. So thank you for being here. I want to say that specifically to you.
Thanks,
Yeah.
Harry. That's really.
Thanks, Harry. Chris, over to you for the last word.
Well, I just wanted to say, you know, how great it is again to see you all and to be able to have this kind of sharing going on. It's fascinating to me, and I you know, we're experiencing something pretty similar, and to be able to sort of hold hands across the oceans like this and share experiences and learn from each other is just amazing to me. I don't know how you manage to do it and bring all these people together, but it's you know, it's the best forum I think that I've experienced and witnessed in the last 12 months. Well done, and thanks for inviting me back.
Chris, you're very kind and gracious. Believe me, this has been a grand experiment. Trying to do epidemiology of like new patterns through rounds is kind of a bizarre phenomena. I'm not sure how it's working out for us, but we're learning a lot from each other. And quite frankly, I mean, at least in my clinical experience, when like faced with no information except a patient in front of you, like the best you can do is learn from each other. And an observation, you know, there's tons of stuff out there about the vaccination and the variants. When I say stuff, you know, lots of like preprint papers and lots of information, you know, what's credible, what's not. But, you know, now, ever since the beginning of February, not seeing anything, no papers on new clinical patterns at all. And so a bunch of anecdote, a bunch of participants saying they're seeing it, but, you know, it's like, okay, where is that evidence and data? And so hopefully, you know, people that have been participating on these rounds will go forth and ask that same question. To our participants, thanks for hanging in there. You know, there's like 114 of you that have hung in there. And I know there's the 1 o'clocks, but this one was enough of sufficient importance to make sure everybody had like some time to share. To our panelists, Carol and those who were on before and had to go to the 1 o'clock, thanks as always. And to Harry and Chris, goodness, just like wonderful. And the same for Vikram, just extraordinary. I mean, I think, at least for me, you know, there was this like, are we crying wolf or is there something there? There's something there. I've gotten to that point. Now, how to move forward with it, I think is our challenge, and we'll keep discussing this along with some of the other critical topics, the mental wellness issues, the surge that could come again, et cetera, et cetera. So with that, thanks again, Harry and Chris, and to Vikram, who's not here yet, or here any longer he's got to get back to his patients for sure. So with that, thank you, and we'll see you on the next one. Bye.